Okay, so this morning I'll talk about first CMC Osteoarthritis. Okay, so it's a common condition, 1 in 4 women, 1 in 12 men. Said that the typical patient's the postmenopausal elderly lady. But I think it's a bit more common than that. So the causes of osteoarthritis in this joint are said to be multifactorial. There's causes that are intrinsic to the joint and extrinsic to it. So the intrinsic causes are ligamentous hypermobility. And this was shown in the 90s. There was a guy that did a case study on patients with generalised hypermobility of joints and found that there was an increased association with osteoarthritis in this joint. Ligamentous laxity is another one, and this is studies that have come from patients with Ehlers-Danlos syndrome, where they found that there's radiological evidence of CMC OA at a mean age of 15 in these patients, which looks quite significant. It's thought to be hormone related, and this again goes to ligamentous laxity with the female preponderant predisposition for having increased levels of prolactin, relaxin and estrogen. And then there's thought to be gender related differences too, which is altered geometry in the trapezium for the females. And then the extrinsic causes, the post-traumatics, so Bennett's fractures, and ultimately these all come down to shear type of wear patterns. So that laxity in the joint causing shearing of the base of the metacarpal over the trapezium with increased wear on the trapezium side of the joint. And it's thought, I should have said, sorry, it's thought that the most important ligament within the joint is the anterior oblique ligament in stabilising against these this laxity. I'll come back to that. So this is just quickly going over the anatomy. It's a saddle joint. There's a whole host of ligaments that I think none of us have ever learnt. But the main one here is this anterior oblique ligament preventing the dorsoradial subluxation that's typical for this condition. So diagnosis investigation. This is a condition where pain is the most common presentation. It's insidious in onset and can be from a spectrum of mild to quite severe and debilitating. Pain is generally around the base of the thumb or through the musculature of the thenar remnants. Patients also complain of weakness and have disability, particularly with wide abduction of the thumb, so in trying to open jars, and they present with deformity. So clinical examination, they have tenderness more over the dorsal side, the dorsal-radial capsule. You can actually palpate the subluxated metacarpal in some patients. The grind test is described as axial compression along the metacarpal causing pain and crepitus. These patients end up getting an adduction deformity, and this is because they avoid abduction of the thumb because it's painful, so they adopt that adducted posture, and this causes contractures over time, and again goes with that stretching of the anterior oblique ligament. They then get a secondary hyperextension in the MCP joint, and this is described as that Z-type deformity, and this is a compensatory attempt to increase range of movement of the joint by avoiding abduction but hyperextending. So in 1973, Eaton classified or made a radiological classification of the condition, stage 1 to 4. Stage 1 is normal articular cartilage with a widened joint space with some synovitis and effusion. Stage 2, mild narrowing of the joint. However, maintained joint contours and minimal sclerosis. This is type 2 in the picture. And there may or may not be lateral dorsal subluxation. So that's compared to type 3, where there is greater joint narrowing. Features typical of osteoarthritis as in other joints, and the joint here is usually subluxated. And then stage 4, there's significant joint degeneration, but also concomitant scaphotrapezial joint degeneration, so it's not just isolated to the CMC. The treatment for this, the mainstay is conservative, and conservative until it's failed, essentially. So hand therapy is aimed at increasing the range of movement, overcoming that adduction deformity, and preventing those secondary deformities, such as the hyperextension and the Z deformity, and to strengthen the thumb muscles to help provide stability and generally overcome that incompetent anterior oblique ligament. Splinting is aimed at reducing that subluxation and again overcoming that adduction contracture. There was a study published in the Journal of Hand Surgery in 1997 that they showed that with 6 months of splinting, they decreased pain severity by 76% in patients with type 1 and type 2 disease. There was another study in the Scandinavian Journal of Plastics, Reconstructive Surgery and Hand Surgery that they had 33 cases that were on the waiting list for operative management of this condition, and that they found with an average of 7 months hand therapy and splinting that at the time of surgery 70% of the patients declined further intervention. So sort of again suggesting the efficacy of these conservative measures. Corticosteroids, as in any other arthritic joint, may have a role. There's mixed case reports in the literature. There's no good study saying that they're good or bad. Quite a few, I think the general feeling is that they're best not used in this condition, that they don't have lasting results. There's a study published in Journal of Hand Surgery in 2001 that showed, if you have a look at it, reasonable pain relief, symptomatic relief in their patients. So these stage 1 patients had 23 months, stage 2 and 3 had 18 months, and they said stage 4 there was really no benefit. But if you have a look at what they're actually advertising or advocating, the number of patients in their groups were very small, and even in this stage 2 and 3 group, those that had 18 months symptom relief, it was only 6 out of 17 patients. So it's a hit and miss as to whether it really works. Perhaps in this early group there's some evidence to say that it's worth trying, but again there's a very small case series. Surgical intervention is reserved for those that have failed conservative measures. And these decisions, as always, are based on things like patient demographics, occupation, which would lead to level of demand, the severity of their symptoms, and then also the radiological severity of the condition. I'll sort of come back to that. So one of the options is ligament reconstruction, particularly that anterior oblique ligament that we were talking about. So the indications, again, those that are refractory, those that have confirmed carpo-metacarpal instability. So this can either be clinically or in the studies they preferably say radiological evidence of subluxation through the use of stress views. And there's some studies showing that this minimises the progression of the disease in those early stage 1, stage 2 conditions. There's a whole range of techniques described. Most of them are aimed at reconstructing those volar ligaments, and most would use the flexocarpi radialis tendon. So this is a picture showing how that's done. You can see they've taken a partial slip of the FCR tendon and looped it through the base of the metacarpal, under abductor pollicis longus, and then back around the flexocarpi radialis. And this is again to tighten, to provide that sling and tighten the joint to stop it subluxating dorsoradially. So again, the results for these, in a study published in '84, the Journal of Hand Surgery, they had good or excellent results. These are all medium-term studies, unfortunately. The stage 1 and 2 showed really good results, and again, these sort of fell away as the severity progressed. A study published in early 2001, again reporting mid-term results, showed good or excellent results with complete pain relief in those with stage 1, and those with stage 2, they had, again, good results with 70% pain relief. This is an average follow-up of 5 years. They then followed this study only looked at type 1 and type 2, which is different to the previous study. With their longer-term follow-up at 15 years, they said the stage 1 had higher satisfaction rates between the two, and significantly 65% showed no radiological evidence of progression of the disease, which is one of the arguments for using this technique early. There are a few studies describing metacarpal extension osteotomy, but it's not something that I'm aware is done very commonly. Again, the indications are stage 1 or 2 disease, and it has to be confined to less than a third of the volar surface. So this is quite significant. A lot of the studies recognise that the radiology and X-rays are poor at showing how bad the disease is, and so that they confirmed that it was less than a third at the time of operation. So again, it really limits the use of this technique. The contraindications of those with advanced disease, as we said, all the hypermobile or fixed subluxation. So again, it's aimed at unloading the joint, but if it's unstable, it's not going to work. The technique is cutting out, it's a closing wedge osteotomy essentially, and they say taking out a 15-degree wedge is sufficient. And the thoughts are that this works by first unloading the articular surface, but also by tightening the capsule that little bit. But again, you need a joint that's not hypermobile. So there was one study published in '98 that had 41 patients, again with midterm follow-up, that they reported that 95% had worthwhile pain relief. So it didn't really qualify it. They also said that grip or pinch strength improved to an average of 90% of normal. So this was compared to the contralateral side. I guess this is one of the other big problems with this condition is how do you measure your outcome measures, particularly with grip strength. Grip strength is difficult. When we said at the start, there's a lot of extrinsic factors that would make this potentially a bilateral condition. If you're comparing a disease side to a disease side, it's not necessarily, it's hard to show good outcomes. Arthrodesis is an option, and there's rare indications for this. This is those with painful instability, a high demand young patient, and isolated stage 1 or 2 disease. The disadvantages with this is obviously lack of movement. There's a high non-union rate, and also prolonged immobilisation. So a lot of the studies describe 3 months of plaster immobilisation, which is obviously difficult in this patient population that's going to be working. So the technique is, the position of fusion is a key pinch grip. And again, just like an infusion, to debride the bases of the bones back to that bleeding bone. And then the actual fixation method, there's been a range of things described. But again, this is not a common procedure. The outcomes, this was published in 2001, again, only midterm results. They had 49 patients. They had an average visual analog scale of 1.5%, which is the reason we're doing this for pain relief. At the 7 years, they had 14% that had progressed with adjacent joint disease, 7% non-union, and they didn't really report any functional or satisfaction outcome measures, which I think would have been nice in this type of study, given that the main criticism of the technique is loss of function. Arthroplasty in this condition seems largely experimental from my understanding. The silicone implants have gone out of fashion for good reason. The high wear rates and silicone synovitis. There are some pyrocarbon or titanium implants that are coming onto the market that have all had a few small case series. This is perhaps the largest that Mr. Swanson published on the Swanson implant. So I suspect there's a conflict of interest here. He had 105 implants, improvements in range and grip strength at six months, and he reported there was no evidence of radiological loosening at 5 years. And this is quite significant because this is in despite much of the rest of the literature, particularly the pyrocarbons and the titanium implants that have been around previously. So I'd say this is not typical results for what others are finding. So overall for these conditions, like I said, there's a lot of small case series, all with short and medium term outcomes. There's a high dislocation and subluxation rate for these implants. It's in the order of about 40%. So it's really prohibitive to their routine use. And 50% implant breakage at 4 years. I think this is more for the pyrocarbons. But again, high failure rate. So the gold standard of treatment generally is considered trapezectomy with or without ligament reconstruction and tendon interposition. So again, the indications here are for those stage 3 or 4s that have failed conservative treatment. There's plenty of techniques described and approaches and how you actually go about doing it. Ultimately, they all come down to a trapezectomy as the mainstay, and then ligament reconstruction or tendon interposition. And again, you can either use the tendon of FCR, palmaris longus, or abductor pollicis longus. There's those that just use hematoma as their interposition, and there's also some synthetic products that are on the market. So if we're looking at the outcomes for these, again, there's no big studies. This is published in JBJS in 2000, sorry, not in 200. That was a prospective randomised controlled trial of 31 patients. that had a trapezotomy with ligament reconstruction or tendon interposition. At 4 years, they found there was no difference between the groups in their outcome measures. There was another study in 1997 that was comparing trapezotomy with interposition arthroplasty. Again, very small study, but they found again at 2 years there was no difference between the groups. The big ones with, I guess, all of these and the big criticism of trapezotomy and the reason for doing the tendon interposition is the radiographic subsidence of the metacarpal. If it's unsupported, the thoughts are that it can subside and then again have effects, on grip strength and contractures and ongoing deformities, which is why we depose the tendon. And these studies, I think, are just too short term of outcomes to really comment on those. This is a Cochrane review on all of these techniques, trying to compare the outcomes in the surgical treatment of this condition. This was published initially in 2005, but it was updated in 2012 and had ultimately the same outcomes. There was no one procedure that provided greater pain relief or grip strength, and that a simple trapezotomy seemed to have the fewest complications. I think this sort of echoes the thoughts throughout the literature. So in summary, it's a common condition. It's certainly much more common than I thought it was. It's important to remember that symptoms don't correlate with the radiological findings. I think that's true for most conditions, but particularly for this condition. Conservative treatment is the mainstay and needs to be pushed until exhausted. When it does come to surgical management, it's reserved for those refractory cases. There's no proven benefit in any technique. However, saying that trapezotomy is the most reliable procedure, and I think arthrodesis should be reserved and considered for those young patients.
Excellent.